Hi everyone, our subject today is chest pain in pediatrics. Chest pain is common in children and adolescents. Despite the degree of concern that it generates, the symptom is rarely associated with a serious cardiac problem. The epidemiology of chest pain in youth is not well understood, although available data suggest more cases are classified as idiopathic than are attributed to a more specific etiology, example cardiac or respiratory. Studies approximate between 1% and 10% of pediatric chest pain cases are due to cardiac etiology. A properly done history and physical examination are often the only tool required in the evaluation of pediatric chest pain. Screening tests are not considered helpful unless specifically indicated. Eliciting the parents or family concerned about their complaint may be useful. A medical history of asthma, sickle cell disease, collagen vascular disease, or a recent coughing illness may be helpful. Long-standing diabetes mellitus and chronic anemia are risk factors for ischemic chest pain. Inquire about a history of Kawasaki disease, including the possibility of undiagnosed cases. The review of a system should include inquiries about associated acute and chronic symptoms and any precipitating factor. Inquire about choking episode, recent trauma, and exercise or activities that could cause pain from muscle strain or overuse. It is critical to distinguish a history of exercise that could cause muscular chest wall pain from exercise as precipitating factor, which may be consistent with the ischemic pain and mandate an urgent cardiac evaluation. Associated syncope is very worrisome and also mandate a cardiac evaluation. A medication history could provide clue to a potentially causative etiology like oral contraceptive or the possibility of a mucosal injury like tetracycline or non-steroidal anti-inflammatory drugs. Also investigate the possibility of substance abuse, especially cocaine and methamphetamine. Evaluation of psychological factor in a child's life is very important. Ask about school attendance and performance, relationships with the friends, family, and any current stress or conflict. The family history should inquire about hypercholesterolemia, Marfan syndrome, and cardiomyopathy. A family history of recurrent syncope or unexplained sudden death may suggest hypertrophic cardiomyopathy or long QT syndrome. Heart disease in an adult family member may provoke anxiety-related chest pain in a younger person. A complete thorough physical examination is necessary. Focusing on the chest exam may miss finding pertinent to the non-cardiac underlying cause of chest pain. How to approach to the patient with chest pain? After performing history and physical examination, is there minimal associated symptom? Ask about or examine for chest wall tenderness. If it is present, differential diagnosis may include costochondritis, other causes of skeletal chest wall pain, trauma, spondyloarthritis, chest wall deformity, osteomyelitis, muscular chest wall pain, pleurodentia, breast pain, mastalgia, fibromyalgia, tumor, cutaneous causes like herpes zoster or hypersensitivity. If there is no chest wall tenderness, differential diagnosis may include asthma, psychogenic, hyperventilation, substance abuse, precordial catch syndrome, pulmonary hypertension, smoking, mitral valve prolapse, or idiopathic. Is there in the history and physical examination a prominent cough without signs of illness or respiratory illness? Perform chest x-ray. If it is abnormal, differential diagnosis may include asthma, foreign body, pneumonia, tumor, other etiology of chronic cough. Or it is maybe normal. If it is the X-ray normal, perform trial of bronchodilator with or without pulmonary function test. If the symptom unchanged or no change in pulmonary function test, differential diagnosis may include smoking, musculoskeletal chest wall pain, other etiology of chronic cough, or symptom improved or improved pulmonary function test. Diagnosis may include asthma. If patient has fever, ill appearance, or respiratory distress, perform chest x-ray. If it is abnormal result, differential diagnosis may include pneumonia, pericarditis, myocarditis, foreign body, sickle cell disease, asthma, pneumothorax, post-pericardiotomy syndrome, pleurisy, pleural inflammation, dissecting aortic aneurysm. If it is normal result, a differential diagnosis may include pulmonary embolism, sickle cell disease, acute chest syndrome, pleurisy, pleural inflammation, or foreign body. In the history and physical examination, is there history of trauma or vigorous exercise? Consider X-ray. If it is abnormal, differential diagnosis may include fracture, accidental, non-accidental, and child abuse. Or normal X-ray may include musculoskeletal chest pain, slipping rib syndrome, or idiopathic. Is there symptom related to meals, position, lower sternal, epigastric location? Patient may need a trial of antacid or H2 blocker. If it is positive response, this is gastroesophageal reflux disease or esophagitis. If it is no response or minimal response, consider upper GI contrast versus referral for GIT specialist for endoscopy. Differential diagnosis may include GERD, esophagitis, peptic ulcer disease, eosinophilic esophagitis, pill esophagitis, or esophageal intestinal disorder. Is there history of palpitation? This will be discussed in another video. Obtain ECG. Differential diagnosis may include arrhythmia, isolated rhythm disturbance, drug toxin induced associated with the systemic disease, anemia, hyperthyroidism, associated cardiac defect, congenital or acquired. If there is heart murmur, also this will be discussed in another video. Heart murmur not consistent with the functional murmur, consult cardiology. Differential diagnosis: hypertrophic cardiomyopathy, aortic valve stenosis, pulmonary valve stenosis, coronary artery disease. If their pain precipitated by exertion or running, is there history suggestive of asthma associated with the dry cough, history of atopy? If it is yes, a trial of bronchodilator before exercise. Differential diagnosis: asthma or deconditioning. If patient not has history of asthma or has pain associated with syncope or ischemic in nature, patient need urgent cardiology consultation. Workup may include ECG, echo, exercise test, cardiac enzyme, event or Holter monitor, urine drug screen. Differential diagnosis: hypertrophic cardiomyopathy, arrhythmia, anomalous coronary arteries, thrombosis due to coronary artery, Kawasaki disease, infarction, or drug abuse like cocaine. Recommended investigation: full blood count may show anemia in sickle cell anemia, chest x-ray for cases of pericarditis, pneumonia, chest syndrome for sickle cell anemia, ECG and 24-hour ECG monitoring if cardiac disease suspected, exercise stress test for suspected cardiac disease, echocardiography for suspected cardiac disease, endoscopy if a gastric source of pain is suspected in gastroesophageal reflux. Top tips. The first clinical issue in a child with the chest pain is to decide whether the history and clinical findings suggest an organic or non-organic cause. Idiopathic chest pain is the most common cause, occurring in 20 to 45% of cases. It is defined by absence of cause for the chest pain through history and physical examination and laboratory tests, excluding thereby organic disease such as cardiac or pulmonary disease. Chest pain, discomfort, or heaviness on exercise suggest exercise-induced bronchospasm. A bronchodilator before the exercise is likely to prevent these symptoms and suggest the diagnosis. Costochondritis, frequently caused by viral infection, is characterized by localized swelling of costochondral, costosternal, sternoclavicular joint, mostly involving second and third ribs. Chest movements or taking a deep breath may worsen the pain. Acid reflux can cause retrosternal or left side chest pain with or without epigastric pain, often presenting as burning sensation. A typical psychogenic chest pain, dull or sharp, of short duration and unrelated to exercise. Teenagers are mostly affected. Inquire about loss of relative, pending examination, bullying at school, breakup in relation with a friend or a close relative who has had angina or heart attack. Chronic or recurrent episode of chest pain lasting more than 6 months without abnormal finding are likely to be psychogenic. This cause accounts for 5 to 10% of cases, mostly in Yale. Red flags. Chest pain in infancy is difficult to diagnose. An infant who presents with sweating, restlessness, and crying as equivalent sign for expressing chest pain may have a serious cardiac disease, example acute chest syndrome in sickle cell anemia, or anomalous origin of the coronary arteries. Serious attention has to be given to children who present with the abnormal physical examination finding, abnormal ECG, exertional chest pain after excluding respiratory diseases, associated palpitation or family history of cardiomyopathy. Referral for further evaluation is essential. When the presentation of chest pain or discomfort is associated with syncope, a cardiac cause need to be considered, such as aortic stenosis, atrial myxoma associated with tuberous sclerosis, hypertrophic cardiomyopathy, long QT syndrome, and supraventricular tachycardia with very rapid heart rate. Patients with marfanoid appearance and chest pain require close attention because they are at risk of dilatation of the ascending aorta and dissecting aneurysm.